lot to be done in coronary artery disease. Though as cardiologists, we could handle the fire but we don't have the fireproofing mechanism. So this is the organization, this is the institute where I was trained as an undergraduate. I'm very grateful for the organization and I'm very happy to be here. And this is the mother institute where, the stalwarts there taught me the cardiology. And this happens to be more than 100, but more or less 100. So in 1997, 96, when we started Cath Lab for the first time in the state, I started our team. That time there were 2-3 cardiologists. So we used to go to different places. This was one of the Ongole IMAs. I gave a talk with a VCR. That time VCR was there. And we tried to show angiogram and what are the clinical indications and how when you do it. So before starting the topic, I'd like to just put questions if some DNB, DM students are there. So if there are 3 vessel blockade, proximal vessels, 80% block in left antedescending artery, left circumflex artery, right coronary artery. Patient is a diabetic, has got stable angina pectoris. On walking he gets discomfort, but on, he's okay with the medication. And stress test is borderline or mildly positive. So what do you suggest? 80% lesions and is 58-year-old. So how many of you feel that it is a straightforward case for bypass surgery? Any students, youngsters, or practicing physicians are there? Is it a case for bypass surgery? Or multi-vessel PCI? Or medical management? So I myself do not know the answer if you give me only this data. So at the end of the session, I will ask you again, then probably you'll be in a better position to answer what is the right approach for this patient. This created ripples in TCT-MD. See, TCT-MD is an online education resource and Cardiovascular Research Foundation manages it. Cardiovascular Research Foundation has now gone into alliance with American Heart Association, which is very, very old, and they have come on a common platform to conduct scientific programs, research, and share the news on interventional cardiology and other cardiology aspects. So there was a clear categorical statement which all of us, in fact, for the past 10-15 years, we have been discussing about this, why we are not able to prevent sudden cardiac deaths. Something is going wrong despite so many advances. So we were banking upon 3 factors. One is symptoms, then ischemic stress test to screen coronary artery disease, and if ischemic stress test, ischemia stress test is positive, taking the patient for coronary angiogram and fixing up some 70% stenosis, where if it is more than that, you have to fix it either by stent or surgery. That is the practice all of us have been doing. But with the data, scientific data, almost for 20 years now, since 2005, longitudinal studies will be showing the results. Now, we know that what we have been practicing was not correct, and many people succumbed, having gone through physicians, having gone through cardiologists, because more than 50% of the heart attack patients, if they are admitted in our ICU, if I see the patient a day earlier, I would say this is a low-risk patient, don't start anything, it is okay. Unfortunately, this is the teaching, this is the concept which we were taught, which we were having it for till almost about 10-12 years ago. So then most of the times we pitch in, and then you have primordial, primary, secondary, tertiary, and quaternary care, right? Primordial prevention in the current generation will be something like cell line genetic engineering, gene editing in the fetal life, and quaternary care is don't do any harm to the patient. So either by omission or commission, that is the quaternary care. And then we have been going with the guidelines like risk factor stratification, which is population based, but we have tried to apply it to individuals. So under treating and over treating, either, even in the screening. And then another important area, eyeballing, where we went wrong. 30 to 40% of the times our angiographic assessment, senior most cardiologists go wrong when you do invasive FFR. But we have been doing ad hoc PCI based on our eyeballing assessment. And that created a lot of confusion, therapeutic confusion, medical management, surgery, or medical management, or multivessel PCI, as I showed the first case. And now we have clarity that we don't do ad hoc decisions in the cath lab. So it is the CT console room where we take decisions for all elective PCIs, all CAD, except for STEMI PCI, where we go enter the cath lab, non-STEMI or non-occlusive, anything, stable angina pectoris, atypical chest pain, non-specific T inversions, whenever you suspect or screening asymptomatic patients, we will show. Now it is the CT console room where it is cool and we talk to the patient attendants and take a cool decision. This avoids ad hoc cath lab decisions which we have been taking, which created a lot of confusion. And then now the digital strategy and the computational planning, how we have started doing already in our setup. We'll show some of the cases, CT guided PCI, which is definitely more accurate and with better outcomes, which is already being shown. For almost, in other words, for almost the same thing, what in TCT MD, what they have mentioned in 2025 California, same thing, you can see this in this article, 2021. And as I mentioned, we have been banking upon the old traditional method and thinking and ignoring the hidden heart disease. And our methods compared to cancer are very, very poor in picking up the hidden time bomb. And this, I'll show some of these statements which are now accepted, based on which the guidelines have changed significantly in 2021 and 23. So treadmill, we have done several thousands of treadmill. Our ischemia stress tests, whether it is a SPECT or PET or dobutamine, echo dobutamine, MRI, any type of stress test you take, now it is shown by NCDR data, several lakhs of treadmills, ischemia stress tests do not give any idea about the reasoning, and because more than 50% of the times these do not show any value, and coronary angiogram should not be dependent on this. And when in 2015, when this article was published, many people laughed at it. What is this warranty for coronary artery disease or acute coronary events? But now we know when the calcium score is 0, less than 1% annual event rate. In some of the studies, 0.5%. It is less than the average person who doesn't know about his calcium score. Right? This is there. And so, during, between 1995, 2000 to 2015, it was a stent era. All of us were carried away that our teaching, our understanding, our concepts were, okay, go, if there is more than 70-80% lesion, better fix it. So, and in the bargain, stent industry, lots of, the problem is the guidelines and the system is flawed when a lot of varied applications are there, and then many inappropriate PCIs were done, and there was huge cry. And in US, they identified places where angiograms were done, PCIs were done, and then they tried to regulate. And after that, and then with time, people have realized that coronary angiogram, you are seeing the hole, you are not seeing the wall, donut, you are not seeing what is happening. And that they have realized, and missing compartment, only 5% of the coronaries you see. And looking at all the results, somebody has suggested in 2015 itself, stop invasive coronary angiography as the gold standard for diagnosis. But nobody agreed, and not until 2021, the guidelines, ACC, Australian, European guidelines have categorically agreed, and then they have pushed down invasive coronary angiogram not for screening, it is only for interventions whenever it is needed. So there is a paradigm shift from cardiac catheterization, coronary angiogram to CT as one-stop shop. How it is, you can see both a plaque, the degree of stenosis, the vulnerability, which is most important, low attenuated plaque, or napkin sign, positive remodeling, or the extent of the plaque. That is the key. Apart from the degree of stenosis, we are talking about 30% stenosis plaque rupturing. It is the vulnerable plaque. And it is the extent of the plaque which is more important. And once you know this, once you have the hemodynamic data, shear wall stress, and then all these FFR, hyperemic, non-hyperemic calculations are there. And once you know that, then you know which vessel really needs. I was talking about 80% lesions in all the three vessels. So with this data, you know, yes, this vessel doesn't need, this vessel needs. You can talk to the patient. So it is a shared patient decision, not in the cath lab. In the cath lab, patients are confused. We have oculostenotic reflex, ad hoc PCI. 30% of the times we are wrong in taking a decision, either under treating or over treating. You can do both. But here, the CT guided PCI and therapeutic decision relieves the confusion, and it is the upcoming and already, lots of people are trying to follow in the West. In India, yes, it is also coming slowly, and it is safer, faster, and then it is truly patient-centric. Before going into the machines and the types of investigations, so these great people we should, cardiac catheterization, 1928, and then Soane's, that is accidentally entered right coronary artery, and that is how coronary angiogram came. And millions of patients, millions of procedures are done. Definitely, it is the cardiac cath lab is the temple for all our cardiology community, because we are very confident we save many lives, especially in acute emergency STEMIs. But slowly, what happened we have seen, and this is another groundbreaking innovation in 1970s, that is cardiac CT scan, for which he is an engineer, and then but he invented this CT machine, and then he got the Nobel Prize. And then he is another great gentleman, Andreas Gruenjig. All the interventional cardiologists, we have a lot of worship for him. He was the first person to do the angioplasty, and a lot of stent technology subsequently evolved. And these are the mentors in AIMS and NIMS, and who helped us to establish a unit here. And these are the two great people who are responsible for the preventive cardiology. So Dr. Narula was my senior, and he used to talk about lipids and then a lot of preventive cardiology, and Dr. Srinath Reddy, well. So this is the magnitude, and that is the reason why you need, and 80% of the sudden cardiac deaths are preventable. World Heart Federation says that. And in India, it is much more important, and the failure to predict and prevent in a walking patient is the prime thing which all the cardiology community, the family physicians, they see a lot of their patients. 2 days ago, they come with fever or something, and then third day they are admitted into ICU with acute myocardial infarction, and if you see, they will have triple vessel disease. That means they were harboring the disease for 20 years, and then they could not give any symptoms, and that it was missed. And this is all of us know, Indians, they have smaller vessels, and then Western, the models are not applicable to Indians, because by being Indians, we are 2.5 times have higher risk compared to Caucasians and the other Europeans. And now it is not a medical mystery. Walking patient is not a medical mystery, and we have to decode why the sudden cardiac death is happening, and all of us know that it is the plaque rupture, as I mentioned, either erosion, plaque rupture, or calcified nodule, and these are the cases in the last 5 years we are seeing young people, and then even doctors, and also two doctors recently must have heard from Gaurav Gandhi, about 2 years ago. He went with chest pain to the casualty. ECG was normal. They did troponin. That was normal. He went back. Again, he had 3 o'clock in the early morning. He went again. This time he didn't get the troponin. He got ECG. It was normal. He went back. And 6 o'clock he was found dead. He was a cardiologist. Right? So this is the enigma of hidden coronary artery disease. And this is also seen in Western countries. And this is the dilemma. And this is what, if you see this curve, the subclinical phase is there above where nobody touches the patient. Either cardiologists or physicians try to make a diagnosis only after an event. Event is either sudden cardiac death or acute myocardial infarction. So we have lost a lot of patients because of this lack of understanding, and this is the neglected zone, and even cardiologists, we enter, to do the intervention or treat after the myocardial infarction. So we have to treat the plaque burden, and that is the way you can make this curve more flat rather than steep, so you can reduce the mortality and morbidity. So artificial wall between primary and secondary prevention is broken. Hidden heart disease is secondary, early secondary prevention, not after the event. So this is all, from stenosis, now vulnerable plaque and patient, hemodynamics, and then this is the same again, triple vessel disease. Now, whether to send the patient to CABG, PCI, optimal medical therapy, we have been breaking our heads earlier. We have been having a lot of debates between senior cardiologists, somebody in US, somebody in Hyderabad, somebody says something, but then nobody knows, there are a lot of gaps in knowledge. And if somebody has got triple vessel disease, there cannot be arguments and debates in conferences, surgery versus this and that, because that's lack of knowledge or whatever scientific data. So with this, now the dogma from CS stenosis and stented, we have come out of that, and that happened. This is the time between 2005 and 15, exponential growth of stent technology, and then we were of the opinion that that really helps. Even in India, you can see the graph, numbers and all. But now, at the time, 2005 to 2015, probably all the cardiologists of my contemporary, we were very uncomfortable with this sort of societal mistrust, and politicians, governors, everybody was commenting, like this, and to some extent probably, many factors were there, but partly it was true. And the expectation, people were thinking at that time, 2005, people were thinking, I have 95% block, they have fixed up, otherwise I was 95% dead. No, it's not true. After stent, again, the patient has problems. Patient's symptoms are not relieved in 50%. And then the mistrust came up. They said, you have said everything is cured. No. So it's not true. We are just temporarily trying to relieve the symptoms. And I was also like this, and what to do with multiple data, contradicting data, and a lot of studies coming up, different opinions coming up. So what to do with this when you see such type of lesions in the cath lab? So most of our colleagues also had the same experience. And then now, in 2011, when we started the intelligent CT scan, there was a lot of criticism that it's not useful, not accurate, the radiation dose is high, and but then slowly it is realized with the longitudinal data from several studies which I will be showing, that the more modern precision and from the phase, can we stent this, to does the patient really need a stent? Should we stent this? So we have reached to that stage, and slowly the gold standard, the invasive cath lab to screen the disease is no more a gold standard, and we know that there are several things happening in the wall which your invasive cath doesn't tell you. And a lot of intracoronary imaging, IVS, OCT, have shown what ordinary invasive cath cannot show. We started understanding the biology, the plaque biology, the extent by IVS, and then the cap, then the vulnerable plaques. And this is how the CT current angiogram has taken over because of all the results and all the data and the limitations of invasive cath. And then now we know what is the vulnerable plaque, what is the extent. And then another important thing, most of the times when I was giving during many of these guidelines, 2014, 2010, if you see, asymptomatic patient, never screen the patient. Now we have the data, Miami Heart, Scapes, 50% of the patients, people, not patients, asymptomatic people in India, beyond 40 to 45 years, will have some plaque. That is very clear, and this is, even in the Western population, more than 50 years, they have 50% plaque. In India, we are a decade earlier. So this is very clearly shown, and this is where, of course, invasive cath with its complication rate, asymptomatic patient, absolutely normal, you may not. But picking up the disease early, now CTCA has become very simple, safe, 5-minute procedure. Now, with this data, which is very, now Denmark and then all these data, it is known that asymptomatic patients should be screened in India more than 35 years or 40 years if they have at least one risk factor, metabolic syndrome, hypertension, diabetes, family history, or hyperlipoproteinemia. So this is very clear now because we catch patients, double, triple vessel disease, proximal LAD, and then they are absolutely asymptomatic. Many patients from US who come here to us for CT coronary angiogram, they come there, they get it, they are surprised. Triple vessel disease. The minute they go to US, they were getting bypass surgery done. I have a few patients like this, and some of them have mid-range disease. They start treatment, they change their lifestyle, because once you see the lesions or the calcium, then you change your lifestyle. Otherwise, whatever you tell, there is hidden bomb and all, clocks and all, nobody believes. You should show them your CT scan, this is your calcium score, this is your plaque, try to cut down, 50% is in your hands. Our medicines work only 50%. So this is what asymptomatic, and then a lot of toxicity, the unnecessary stress tests, nuclear stress tests in US, and then the timing of the stress test, and then pitfalls of visual estimates, as I mentioned. It is just flipping a coin when between 40 and 70% or 80%. If you want to say whether this is significant or not, you don't know by invasive cath. So then oculostenotic reflexes, all these things. No, now it is plumbing myth. So don't stent any lesion you see. Now you understand, try to understand, study it, and see the correlation with the other factors, and then follow the patients. And that is how, with all this data, I'll show some other studies also, the calcium score, which was refused to be accepted as a paper in 1989. It took almost 30 years. Only in 2020, calcium score was included in the guidelines to screen the patients, and everybody felt that it is much more superior to your traditional risk factors, or CRP, or lipoprotein A, or whatever risk factors you say, and then this is much more superior calcium score. So it has gone through several, obstacles, and then finally it was accepted in 2020. And then there are several other longitudinal studies. I won't go into the details of these studies, but then every study has shown that based on the other risk factors, this is much more superior. And then the accuracy and radiation dose were two other factors which were strongly pitched against CT coronary angiogram. It is wrong. Now we know that it is as accurate. We have shown even in 2012, our coronary angiogram pictures and CT angiogram pictures very clearly demonstrating, and then now it is accepted that it is very, very accurate in majority of the patients. And then the radiation dose is 50% of the invasive cath. This is very clear. And then with the PCCT coming up, photon count CT, it will be much less than what the current dose also. And then the calcification, the cardiac cath has got limitations in calcification, identifying calcification. If you want to do in interventional cardiologists need the extent of calcification, the arc, the thickness. Otherwise, sometimes we are stuck. We used to get stuck in 2000, 2005, try to pass the stent. It was apparently looking okay, but then there was a calcium spur or density. Stent was not going into the bend, and we used to face a lot of difficulties. So one of the greatest limitations of invasive cath is you can't identify, you can't measure the calcium. So then these are the studies which are the critical shock waves, and then where the limitations of our aggression are known through this, and then the CT scan versus risk factors, stress test, invasive cath, then CT scan versus CT-FFR, then CT-FFR versus plaque morphology. All these are through these trials, and then and the Pacific Advanced Registries, NXT trial, heart flow. Now we have come to a different type of the classification. So whether the patient has got no coronary artery disease and mild coronary artery disease, 1 vessel, 2 vessel, 3 vessel, based on several other factors, you take a decision. These are the guidelines which have changed the whole scenario of our cardiology community approach for screening of the cardiac patients. For every patient, either stable angina pectoris, non-STEMI, or typical or atypical chest pain or ECG changes, if you have a doubt in the ER, we wheel the patient to our CT scan room even in the midnight. Then we find either a stentable lesion or a moderate lesion or no disease, we send the patient directly home from the ER. Earlier, we used to have the patient from the ER, chest pain unit, 2 days, 3 days, heparins, everything, and then do the treadmill after a week or 2 weeks, then put the patient. All these 2 weeks, patient was in terrible stress, and we were in doubt what to do, what we are doing. So a lot of wastage of these things, and then now post-CABG, post-PCI, and all these different subsets of patients, CTCA guidelines are there. This is very, very useful, and this is one FFRCT has received class 1 indication. This is what we started in our unit. Across all the units, any cath angiogram, we can do FFRCT. What is this FFRCT? It is a computational fluid dynamics. You measure the pressure above the lesion, below the lesion. How do you measure? Blood is considered a Newtonian fluid. Newtonian fluid is like water, which is not compressible. Viscosity is lost. But blood loses its viscosity little bit when it enters the capillaries. So based on that, different Navier-Stokes equations and lots of physics equations are applied to the density, the velocity, the proximal boundary condition, segmentation, the coronary mesh. They do all these calculations. It is a patented product initially with Heart Flow, California. Now several other on-site FFR machines are available from China, Korea, and all these. And then this is science, and then this is based on all these. The FFR is based on, now you don't do invasive FFR, it has its own limitations. Now CT-FFR was compared with invasive FFR, and people found it to be very, very reliable. The complications of the device they use in FFR, vessel perforation, not being able to do all the vessels is not there. You can measure any vessel. I will show you how we do CT-guided PCI, CT-guided CT assessment of our coronaries now. So these are all the trials which are shown, 10 years trials, and then, so the precision in cardiology. Now we are reaching, though we don't say that we have reached. I will show you at the end where we have reached. But then at least we have better direction now. The variability in practice patterns is not there because there are definite guidelines. FFR less than 0.75, 0.7, you try to fix it. If the patient, it's amenable. If it is 0.9, don't touch the vessel. If your eyes may say it is 80% lesion, don't touch it. So we have tried to identify, and then what exactly, and then of course the other things which are coming up are perivascular fat. Okay, inflammation. If one vessel shows vascular inflammation, low attenuated fat, that vessel is culprit. If 2 vessels have 80% stenosis. So now, from darkness or whatever, 40 years we have, now we have better clarity, and then Now this is what CT-guided PCI I was talking about, and then a lot of management decisions have been changed. What we were thinking, looking at the invasive angiogram, now we change the decision if we have the same patient CTCA by looking at the morphology, hemodynamics, and then we change our approach, and this has resulted in positive outcomes in several of the decode, decide registries, reveal plaque. Lots of longitudinal studies are there which have shown that the management plan can be changed once you have better understanding of the physiology and anatomy. So CT coronary angiogram, which was ridiculed once, now it is accepted like any other innovation. Initially it is ridiculed, then argued, then accepted that, oh, there is nothing much in this, this is a common procedure. So these are all the studies, fish and chips, and several other studies like Korean advanced, all these studies are there, which have shown clearly that number of cath angiograms can be cut down to 60 to 80% of the times, and then the results are better. And then if CTFFR, if you do more than for results 0.8, outcomes are poor. If you leave, the people do better. And if it is less than 0.75, if you fix it, if you address it, outcomes are better. This is very clearly proven in all these studies. And so the cost effectiveness also people have studied, and this is what the digital strategy, what we do, and then lots of, in the past 1 year, lots of articles are coming up, guidelines are coming up from ACC, SCCT, then AHC, and here this is how, how to do it. You try to identify. And once you have the visual illustration, we try to measure the pressure gradient from distal to the proximal, so you know which lesion is more significant, and then if there is step up and a lesion, single lesion, better fix it. If there is no sudden step up, it is a gradual step up, then it is a diffuse lesion. Either you manage the patient medically or you try to get a target and try to fix it by a graft. So that is better than PCI in patients where there is a diffuse disease. So we have three-dimensional. Cath angiogram is a two-dimensional picture. You have three-dimensional pictures. You see multiplanar reformations and cross-sections. Then these are all this is how the physiology we derive, and then lesion-specific measurements. Then we try to fix up these, and then we have a one-page procedural plan. We started doing it, and some of the cases I will show you how it is helping. Once the same, your OCT shows, MLD. So when you have to measure whether there is, what is the length, what is the diameter, what is the morphology, and based on that, what is the size, you fix up the size. Most of the intracoronary imaging is done to measure the size. But then now with this, probably the role of intracoronary imaging will come down significantly, except when you are doubtful about the expansion. And we are trying to see whether we can correlate it with OCT and all. If OCT also shows that your CT-guided PCI is good enough, then probably you may avoid the intracoronary imaging. And this is all the proven. Another important factor, by CTCA, you can measure the calcium density, the arc, and upfront you can decide whether you need to go with either IVL or a cutting balloon will suffice, or orbital atherectomy. You can plan your strategy and decide the device. So the length, everything, people have correlated CTCA with IVUS and OCT with regard to the plaque, with regard to the dimensions, with regard to the morphology, and then calcium is not uniform, and then it is of different densities and dimensions, and this is how you get in our cath lab. And then in CTOs, it's very useful, CT coronary angiogram. And then prior to CABG also, where to put the graft. If the gradient, the virtual FFR is below what you see, the segment which is mild disease, then if it is high, then you put the graft below. So you can guide the surgeons where to put the graft, whether, likewise. And then, so even left mains, there is correlation with IVUS and then CT coronary artery, the plaque, the area. All these things are coming up in a big way, and this is how the virtual stenting, and you imagine when you stent, what will be the FFR below? If it is less than 0.9, it is likely to fail, stent is likely to fail. And so these are some of our cases where we tried to measure and then see the non-calcified plaque and calcified plaque. If the total plaque volume is more than 750 millimeter cube, it is more prone for vulnerability, rupture, and outcomes, bad outcomes in future. And then this is how we do FFRCT in our setup. This is a United Imaging, and where they have applied machine convoluted neural networks and probably even quantum computing, which will give better pixels, better segmentation, and better measurement of the pressures. In future, it's going to be more accurate once the quantum becomes more and more utilized. And then some of the cases which we have followed. This is one of the doctors where we have followed. In 2017, the FFR was 0.88. Okay, in 2021, it was 0.79. The doctor plays shuttle regularly. He is asymptomatic, though it is less than 0.8, whereby standard guidelines, and it is very tempting to stent it. We didn't stent, and for the past 5 years, he's doing well. So what we know is only up to some extent. And looking at this, anybody would stent. I don't think any cardiologist, if given this picture, will stent. But then he doesn't need probably lots of things, lots of black boxes, invisible collaterals. We don't know what is happening in this patient. And likewise, the length we are trying to measure, Manohar, Ramesh, all our people are now at it. They go to the CT console room, they measure, and then they go to the cath lab, they stent, they do the OCT, and try to correlate whether this was correct or not. So we are trying to improve how we can see that there is correlation, we can assess better, we can do better in this. And likewise, the calcium arc, and these things are being measured, and these are all our patients. And then this is how the OCT we are measuring, and ultimately these are some of the patients, and this is the virtual decision confirmed by physical reality. You are seeing that white line, that means it is a fully expanded stent. And then, so the computation ends the debate on medical management versus bypass surgery versus multi-vessel PCI. And what is the take-home message? Take-home message is what I know of cardiology is only tip of the iceberg, because there are several areas, genomics, epigenomics, black boxes, the alpha fold protein and the single cell atlas, which is going to come in a big way, dynamic molecular interactions in the atherosclerotic plaque in an individual, what is the coagulation parameters, what is the bleeding tendency in that particular, we do not know. Probably these will be playing much bigger role. What is the microvasculature? Very, very important part, which is neglected. We were happy about the epicardial stenosis. Okay, we have nicely stented, but then all the microvasculature is clogged. Patient develops LV dysfunction, aneurysm. So we were perplexed. What is this happening? We have done a very good job. No, we didn't know what we were doing, but we did something, right? And then the doctrine of replacement. So replace stenosis with plaque biology. Eyeballing doesn't help in cath lab. It is physiology. And it is a shared patient decision in the CT scan room, not in the cath lab. Ad hoc, you need 2 stents, 3 stents, patient is perplexed, attendants are perplexed, not prepared mentally, not prepared financially, but we think we are doing the right thing, but this is all. And the triad of anatomy, physiology, biology, and then try to pick up the disease early when the spec is there, the calcium spec is there. So he has got a propensity, the LDL cholesterol or lipoprotein A, which is less than 70 nanometers, can penetrate the vessel. So this patient has got that genetic propensity. He may have diabetes, but he may not have that penetrability. He may have large buoyant LDL. It may not penetrate. So he's safe. Diabetes for 15 years, 20 years. We go to the cath lab thinking that this guy is going to have triple vessel disease, hypertension, diabetes, smoker. absolutely clean coronaries. We are surprised. Nobody knows till you do the angiogram. So, but identify the disease, allow it not to progress, allow it, see that you flatten the curve as we have shown, and the mandate is anatomy first, but prevention always, and this is two-compartment model. We should understand that what you are seeing in epicardial coronaries is just 2D imaging, and then this is how the signs and then the hemodynamic parameters, the vulnerable plaque, and the CT control room, and then future is again regenerative medicine and digital twin and quantum. We are happy to have Quantum Valley in Amravati, and it is going to give healthcare is the most benefited of all the walks of life. Pilotless, it could be pilotless cars, it could be missiles, hypersonic missiles, everywhere it is useful. But then in healthcare, because human body is a supercomputer, probably quantum much more bigger than quantum computer, what is happening in your cells, how your morning Madam Anusha was talking about exosomes, the regenerative medicine, you can grow anything from your skin trophoblast, right? Your skin trophoblast has got the memory of your embryonic cell. You put in Yamanaka factors, culture media, there are 4 factors, SOX, something, and then you can command, you grow heart, you grow my liver, you grow my kidney. So it is going to happen. Already they have grown. They have shown in the laboratories, and it is going to happen. The digital twin is again the human in silico. So what my genome, what my epigenome, what my real-time activities are there, real-time transfer to the gene, digital twin. So the drug discovery, the surgery, the medication, how all other factors are affecting on your digital twin. So this is the future, and then probably the future, smart stent. The stent will tell you, oh, I am getting stenosed. Stent will tell you by, smart stent. It will by the radio frequency, you will have that, and then it will tell you, so go and address it. You may not have symptoms. Silent occlusion is not uncommon in stents. And then, so it will be probably 2035. So Anjit will become a solo intervention. Where is Anjit? So all young cardiologists will become, solo interventional cardiologists with the help of virtual assistants, then quantum mechanics, and all this. So this is what the CTCA, so many debates, so many things. If you see the literature, lots of fighting, surgery versus PCI versus medical management, then CT versus CAT angiogram. No, I can't see anything in your CAT angiogram. So likewise, but slowly people have realized the quality, the technology has improved, and data is now sufficiently accumulated over 2 decades. So this is where we are. Thank you for patient hearing in the free lunch session.